is that, I mean, eventually they think maybe it's just a fault with this webcam, but obviously I'm covering the same thing as in the other. So maybe by Friday, they have to come in when the classroom is vacant and take this stuff apart and probably put a new webcam in. I don't. We'll see. All right. That is, nice to have you back there. That's it, and we'll get going from there. All right. So here's where we left off. And so in general, why is this an important topic? Really, pneumonia is the fourth most common cause of death in this country, but it's the number one cause when you talk about infectious disease. That's very significant. So I mean, we have heart attacks, you have strokes, you have cancers, but then you get to this, and now we have an infectious origin. And most of the time, it is a secondary infection, meaning you have some kind of primary infection in the sense. Normally, it's a viral infection that is a first infection that weakens the lung, predisposes you to bacterial infection. It's almost all the time it's your own bacteria. This is something you typically carry with you. In the vast majority of the cases, it can be another kind of pneumonia. Like you'll see, we'll talk about walking pneumonia, even though it would be very unlikely that you could get. That's a bacteria. You could follow that up with another bacterial infection. So that's one of the questions I have on this Blackboard exam that we're going to do a week from tomorrow, which is, and I'll send all the instructions and stuff like that out, which is the distinction between primary and secondary. What's a secondary infection? What's a primary infection? Primary means the first one. Secondary means that infection paved the way for the other infection. Basically, it's fairly straightforward. So and language is very important whenever you're answering those kinds of questions. So we start like this. The big problem, you can't breathe. Why? Because the alveoli, those wonderful little pockets where we exchange oxygen and carbon dioxide, are chock full of fluid. And you can't go through the fluid. I mean, oxygen and carbon dioxide are elegantly designed that you have a lining cell here and a lining cell here and a super thin membrane like the scantron sheet between them, and they pass easily. But if you clog that all up with a big obstacle like fluid, it's just not going to get through. The oxygen just can't get through it, and the carbon dioxide can't get through it coming out. Ergo, and so really that's the underlying response. If the inflammatory response is part of it filling with fluid, that's what inflammatory things do. Not today, but we'll probably do the little COVID nugget and talk more about what are called pro-inflammatory agents, things that made that as serious as it was when we were exposed to it for that first time, roughly 6 years ago last month. And you can see that's a powerful statement in and of itself. So typically the things you look for, and this one of them is a little yucky. If you're going to go into a clinical field, it's all about the sputum. What is a hallmark of most pneumonias? Not all. It's typically they're damaging the lungs. And look, the lungs are just zillions, billions of little air sacs, and around each little air sac, there's a capillary bed. You saw that in A&P when you do the lung up there. You can inflate it, but it's membranes and blood vessels. That's all it is. So whenever one of those membranes, whenever one of those little sacs is damaged in any way, shape, or form, basically immediately it damages the overlying blood vessel. That's part of it. And at that point, you get blood that comes in. The question is, what happens? Is the blood? This is where it ties in with what you did last week in lab. Hemolysis. Most of the pneumonias are caused by an alpha hemolytic organism called Streptococcus pneumonia, we talked about last time. Okay. Streptococcus pneumonia, it's not going to be red. It's going to be kind of a brown or rust colored sputum. It's beginning to partially break down the hemoglobin. Not totally. We talk about Klebsiella pneumonia, you're going to see it doesn't do anything to the hemoglobin, but it damages the lining so much that you get almost a cherry red kind of sputum filled with blood. Other ones don't have that. Tuberculosis is like a mixture. You get almost like a swirl, is the way they describe it here. It's absolutely correct. You get the typical mucus, that kind of greenish color, swirl with little bits of blood. It's just, and so it's a very distinction. And these are all the things. We look at the sputum, we test the sputum, Because that's how you figure out what bacteria it is. You get a clue from what it looks like, but if it's going to be tuberculosis, and you did this in microlab, you test for what we call AFB, acid fast bacilli. That's what the order is going to be on the chart. Sputum culture for AFB. So have the patients cough into some kind of a container, send it out to the laboratory. The lab will come by and pick it up. So that's sort of the nugget about this. So we look for what's coming up. Is it pus? Is it blood? Is it mucus? Exactly what's going on, because that really gives us that interesting kind of clinical clue. The big deal, and this is why in the old days we said, "Oh, we're worried about somebody spiking a fever." This is why I framed it in the morning class. They used to have the chart at the end of the bed, not the main chart, but they had the vital signs chart. And you come in and look at that, and at the end of the bed, I saw VA hospitals long before we had, everything was computerized and no paper. And you map out the temperature, you map out the blood pressure, and the temperature would go up. We call that a spike. And the first two things you think of with spiking a temperature, sorry to bring this up, are pneumonia and a blood clot postoperative. Because we had people, because in the old days, you'd have somebody, I would do a foot surgery, elective, no risk, no infection, didn't use antibiotics. And you would have them, they come in the night before, they'd have surgery that day, they'd stay for probably 2 days after that. And so you worry about people if they're in the hospital in bed for long periods of time. And that's one of the things we look for. Blood clots, because they're sedentary, not moving around. And two, pneumonia, for the same reason. They're like this, or not moving around. And if there's going to be a problem, particularly post-anesthesia, you worry about pneumonia. That's where it comes from. So coughing, chills, shortness of breath, fever, chest pain, all of these, or sometimes some of these, and you might see a change in their color. So that's what I really think of fever being a spike in fever, difficulty breathing, chills start to suggest that something's going on in an infectious standpoint. All of these are. And then you basically, you're doing an assessment. They'll teach you this if you're going into the clinical curricula, being able to listen. You can hear the fluid, you listen for different kinds of sounds. You want to make sure that the breath sounds are clear. They talk about things called bronchi and rails, rattling kind of sounds. And those sounds all tell a story. And you'll learn where to do that, all of that stuff. I mean, it's all, there's a basis. You probably learned about anatomy. Did you hear, when you're doing anatomy in the bone and muscle section, did you learn about the triangle of auscultation? It's not the Bermuda Triangle. It's trying to be clever. That's an area between the trapezius, latissimus dorsi, and the scapula. And it's an area near the scapula where it's basically there's not muscle coverage. So that little triangle is where you can actually hear the lungs. And that's why that's where you know where to put the stethoscope. There's a reason why you learn anatomy, because you know where to put the stethoscope, you know where to get the injection. All those surface markers. You know the notch here, so you can do a tracheotomy. You can feel the xiphoid, so you can do compressions in CPR. That's what that's all about. It's good to know. So, and then they're going to show you a chest x-ray, and you'll see just how so much fluid is in there. I mean, x-rays, basically, it's like an old photographic negative. What happens is, you all know bone looks white on an x-ray. Calcium looks white. It absorbs the x-ray so they don't get through. And therefore, they don't expose the negative. They don't expose the film. If it exposes the film, it stays black. If it doesn't expose it, it stays white, and obviously shades of gray. And you're going to see fluid in the lungs is somewhat of a whitish shade of gray. And then you're going to see that x-ray, and you'll know that there's fluid there. That's what we look for. What do we want? Okay. Quick. Message from the Almighty. And she's been mad at me, so I got to be on my best behavior. Not that any of you in here would be like that, because you're nice to me. right. Nevertheless, so that's all of those things. You're going to see that. Okay, and most of the time we call them opportunists. Most of you are not going to see a lot. If you're going into nursing, if you're going into one of the clinical fields, health science fields, understand the typical med surge patients you're going to see are older. That's who gets this. Maybe very, very little kids, but most of you, even though that may be an area where you want to go into, you're not going to start there. Basically, they're going to start you on a standard clinical floor, a med surge floor, because you're going to see, and most of you are going to be old, and most people are going to be sick with underlying diseases. That's who gets pneumonia. There's two types of pneumonia, just like there is MRSA, community acquired and hospital acquired. The hospital acquired ones are very bad. They are, they have a much higher incidence of death, of mortality, where the community acquired ones are a little bit easier to treat. So as a general thing, but they are typically things that you have are part of you, as you will see. They're relatively easy to contact. And the big sort of clinical factor we see with all the major ones, capsule. The capsule makes it difficult because the way we deal with any invader, we gobble it up. And inside, remember that it's a macrophage. It fuses with a lysosome. You get that phagolysosome. Is that ringing a bell from a long time ago? And it gobbles it up and destroys it. Not what happens, because the capsule makes it hard to do that. And then a lot of his inflammation, that's where it's going to dovetail a little bit into what we learned about, what you will learn about COVID, with a lot of these pro-inflammatory agents. It triggers a lot of inflammatory response, and that doesn't make it better necessarily. In the case here, it makes it worse. And then pain associated with it is pretty understandable from this. And here they are, community acquired and healthcare associated. So the community ones are contagious, but most come from your own. And that's where you're going to see, but and it has three names. If I didn't tell you before, I'll tell you again. It's the one that causes a lot of the ear infections. That's that. Thanks, Mark. Perfect. Streptococcus, and about 30 to 50% of us have it. It's got like different names. We call it streptococcus pneumonia. Of course, microscopically, it's typically a diplococcus. We call it diplococcus pneumonia, and sometimes we just give it one name, pneumococcus. They're all the same thing. So whenever you hear these from whoever is instructing you, they're all the same thing. Unlike me, you have the luxury of coming up and asking me, is this the same thing as this? Most of the time I would tell you that. It's a pseudonym, AKA, also known as. Yeah, my wife would tell me my AKA of Elizabeth PIA. Not PIA. Or RPIA, Royal. Antimicrobial medications, useful, okay. Not effective for viral. We really don't have things for that. Viral pneumonia is like influenza. It's really supportive care. We do have some antivirals that are useful if they're early. We're not going to do influenza. That's Friday. That's a big topic for Friday. And a lot of these are, the big problem in healthcare is right here. This is when you're going to start. Remember, I started talking about things like ESBLs. That's where you run into. And you're going to see it here without me having to write it down. Extended spectrum beta-lactamases and something called carbapentamases. Basically, it produces enzymes that destroy the agents that were most likely to attack it. And that's why there's a lot of fatalities when we see this. And again, a lot of this is there. A brief word about the pneumonia shot. This is all for pneumococcus, has a lot of different subtypes. The pneumonia injection, when we had problem with flu shots, they recommended this for a lot of adults. That way, when the flu vaccine was really a poor choice or a poor formulation several years ago. Generally, it's reserved for people over 60 because they're much more likely to contract pneumonia. I had stopped smoking then. I felt good. I just basically told my family doctor, let's go without. So it's not something, it's recommended, but it's your particular option that's there. And I keep saying, and it's just such an important point of emphasis. Some immunizations are very, very valuable, like MMR and the typical DPT, the tetanus shot. We talk about that a little bit today. But understand, any type of invasive treatment has the potential for complications. So it's always this. Some of the complications, tetanus shot, overwhelm whatever the risks are. And that's typically in medicine and in clinical practice, you're constantly doing that scales of justice thing. What's the benefit? What's the risk? And we'll see which way it tips. So moving on, this is pneumococcal pneumonia, 60% roughly. The vast majority of adult community-acquired things, and they will require hospitalization. Not one you typically treat at home, at least not initially. Cough, fever, chest pain, relatively short incubation period. You start like a cold, next thing you know, I can hardly breathe, I'm in pain. Okay, and you can see that. And when you start to get to fever and chills, that's trouble. It means a lot of these inflammatory agents. Rust-colored sputum, that's a real giveaway. Again, this is alpha hemolytic. This way, it's good because I want to tie in lab with lecture. Okay, because you're going to see the next one. I'll explain to you about it from a lab perspective because you did that. You're doing that lab this week. If you have, I know some of you have lab this afternoon. Severe chest pain aggravated all the time by breathing. Color becomes, and I mean heavily, a lot of perspiration. The likelihood of survival without treatment depends on your own physical condition. Someone who's you or I, even I, considerably older than you, being relatively healthy would likely survive. But I mean, somebody who's really has a lot of underlying problems would not without the advantage of antibiotics. In the pre-antibiotic era, I mean, this was very rough. You just supportive care and hope the fever would break, and some would survive and some would. It wasn't a great survival rate. Here's what it looks like. This is the Diplococcus or pneumococcus. The chains or pairs, either one appear. So, but we frequently see a fair number of these. It's not a perfect cocci. They have that little tiny kind of spot on it they call a lancet shape, like a little pinpoint protruding, big capsule. In that take-home material that I send, that sort of self-learning. No, this was that unit that you did on genetic transfers. We talked about transformation, conjunction, transduction, all those things. By the way, we may have seen that animation, but this is really a response. That capsule, this is what was shown in 1925 that I talked about, and we have it on the PowerPoint if you go back and look at it, where Dr. Griffith showed that the encapsulated strep pneumonia was what caused the mouse to die, not the one that was unencapsulated, because they look different microscopically and on a culture plate. But when he killed the encapsulated one, he mixed them together, and he found that was how genetic material, even from a dead bacteria, could change a living bacteria. That's what we call transformation. So this has been around for a long time. But we know the capsule is the critical, that's the virulence factor. Virulence factor is an important word, particularly in this one you're doing on Thursday. So that's a really good view. It's like a snowstorm. You can't see through it. It's like some of the fog we get here in these mountain valleys. Oh my goodness, you can't pea soup, right? So you can see the heart shadow here. That's the shadow of the heart, which is a very dense muscular structure. But everything else is clear. Here you can see the outline of the heart. Look at the right lung, filled. That's a really severe pneumonia that's there. So the capsule plays a significant role. There's other factors. You can read through this. It's not a big deal. Difficulty breathing. And the problem is, like all of these, it's in your lung, and it's a very fragile membrane. It could tear easily from all the pressure that's on it. And then these bacteria get into your bloodstream, and you're going to see it's particularly true of tuberculosis, where if your heart valves are damaged, we talked about that with rheumatic fever and heart valve. This is called bacterial endocarditis. That's immediately life-threatening diagnosis if it's acute, meningitis, etc. So normally with antibiotics and appropriate treatment, it's eminently treatable, but it has to be got. There's no substitute for identification and rapidly treating. The earlier you get on it, the better chance you have. Up to 30%, I would say it's higher. And healthy people carry that encapsulated one. It impacts that mucociliary escalator, all those wonderful ciliated, pseudostratified, ciliated columnar epithelia. I'm mentioning that for a reason. That will most likely be a final exam test question. I've told you 1,000 times, I'm a nut for epithelium. In the bladder, you're going to learn about transitional. If you haven't heard about it already, digestive, simple columnar. I didn't tell the other guys because I like you best. Don't tell this guy over here. He's cutting class today. Got that? Good. Terrible. And here it's all about the vaccine. Increased risk in those over anything that impairs your defenses, young or old. Over 50. Again, the immunization typically for age, you can see 65 or older. So it shouldn't be surprised if somebody talks to me about that. With heart or lung disease, diabetes, or cancer. Thankfully, I don't have those. Klebs. This is the one in the hospital. This is the one, the sputum looks cherry red. It's disgusting. They have a picture. It doesn't reflect the degree of redness when you see this. They used to have a much more vivid one, that kind of color that was there. It was like, oh, if somebody brought that up, you'd be scared to death. It is a normal enterobacteria. It's in your gut. It's in the colon. What did you test or are testing in lab this week? You inoculated some tubes for energy, correct? Some of you had lab. You inoculated tubes, nice little interesting colors. They were green, right? Sim tubes, citrates. I know this. You did E. coli. You did Proteus vulgaris. You did Enterobacter. I used to order this. It only hurts people who are sick, and as well as a strain of salmonella. When I would do the labs, and I'd ask Mrs. Maurer, who does all our labs, runs all of our labs, to take care as well as teaches. And this Klebsiella pneumonia, it's a cousin of Enterobacter. Okay, the difference happens to be one particular test that distinguishes. They almost look identical. This is normally in your colon. Okay, and the trouble is people are incontinent. People have catheters. Understand when someone's sick in the hospital, in bed for long periods of time, a lot of times there's a big problem with fecal contamination because they'll reach down, they'll adjust their bedding, their clothing. Maybe they had an accident, and you reach down and you feel we're not watching people. We don't have a camera on them 100% of the time. Gets on their hands, somehow gets on their garments. They touch their face like we do thousands of times a day. They can inhale it. They can swallow it. You get the idea? Pretty easy to get in contact with it. And this one is very severe, much more so. Again, a similar incubation period. The symptoms are similar, but we see it much more so. And the sputum is an identifier that you confirm with culture. Okay, repeated shells, this bloody jelly kind of sputum. This gives you the gelatinous, but not the color. It has an enormous capsule. Again, the capsule is the significant feature. It's a gram-negative rod, normally found in yours, mine, everybody else's GI tract, even sometimes mouth and throat normally, interestingly enough, because it depends on what you ingest can sometimes carry this as well. And so other things, medical equipment, colonize the throat, adheres well, the capsule is the big factor. Tissue death, lung abscess, that's what causes all that bleeding. Permanent damage, much more so than streptococcus pneumonia. This does the abscesses, it damages the tissue. So even though if you or I have pneumonia, I don't know if you've had it, I had it years ago when I had just stopped smoking. It was actually the first time I went full time here in 2010. I got it the first 2 weeks I was here, early in September. It's horrible. So I had to stay in bed and couldn't teach before we had remote instruction, all of that. But but you recover from that. This lung abscess, okay, and it's really bad. Septic shock, because it's a gram negative. It's inherently nasty for you. It's all over the place. Typically, we harbor it. Affects very old or very young or compromised hosts. And this is what you see in the hospital, notwithstanding alcoholic and drug usage. But sick people are in the hospital. That's the problem. They're there. And so even if they're there, it becomes part of it. If someone in it, it can colonize areas that you don't even suspect. Nursing homes, very resistant. And we're seeing, this is the multi-drug resistant part of it. These are these ESBLs, plasmids that move. Extended spectrum beta lactamases and these CRP ones, these CKRP strains, carbapenemases, very little. If they have this, I mean, you're talking about half the people dying. This is what I mean by superbugs. And it's scary. So all this, no vaccine, look at a lot of infection control. And that's what I commented on before. You know, the infection control officer is a very important part of the institutional setting, hospital, nursing home setting. That's a big job. Trouble is, one of those jobs, you only deal with problems. It's not fun. Mycoplasma pneumonia, walking pneumonia, what you are more likely to contract than I. Okay? And walking pneumonia is a major issue. Okay? Because we typically see it in military where they live in barracks, in basic training and things like that, or close quarters, whether it's dorms, whether it's crowded classrooms. It's just not that severe. We talked about it before. We talked about mycoplasma early on. There are bacteria, but they don't have a particularly well-defined cell wall. So cell wall antibiotics like penicillins and cephalosporins don't work. So you either use what they call macrolides, which is the Z-Pak, erythromycin or azithromycin, or tetracyclines work well, like fibromycin. Those are really one. And then walking, because the recruits would still have to drill and do basic training. You weren't sick enough to say, okay, you can get the day off, historically. That's where it got its name. But it's not, the trouble is it takes a long time to come on, and things that take a long time to come on take a long time to go away. And really, the contagious nature is because of the close quarters. It's not so severe. It doesn't mean, if you get over it, doesn't mean you won't get it again, because there's a number of different strains, and like any of these other things, they tend to mutate. I would not ask you about this. It would be lab anyway. This is a very good illustration of this kind of fried egg. A lot of things we distinguish how they grow on different augers. This would not be easy to grow either, I would think. And so this is it. It has a high infectious, a little low rather. Small infectious dose means it's easy to transmit. Again, usually it always affects the cilia, very inflammatory in nature. So I remember that. Droplets shed before people are symptomatic. So someone's just coughing or sneezing around you. That's why you're relatively, like here, we're spread out. This is not overly crowded, this type of thing. But I'm sure, I mean, I don't know how, is there a particularly crowded classroom that you're in where people are just, when it fills all these 40 seats, then there's a greater degree of risk. When I was in college, we'd have these mass lectures, like Eco 101 or Psychology 101, whatever those. You'd have 500 people in an auditorium. In an auditorium seating like this. Okay. Just, like the old, like when you had assembly in high school, that deal. You got the idea? So we had, our Chem 1 had 250 people lecture. It was pretty common that were there. So again, macrolides, which are the erythromycin or the Z-Pak, are typically the drug of choice that are there for that. They have a nice summary for all of those things that are there. Which bring me to the interesting. Let me just answer this. Very good. Whooping cough. This sums it up. Vaccine preventable, but endemic in many countries, even here. If people are not on top of, and it all comes from the tetanus shot. The tetanus shot is a trivalent vaccine, meaning it has, you're getting three, and this is MMRs, trivalent. Your immune system, if it's going to be challenged to form antibodies, or to, be in a preventative nature, three is usually the number that we, with a typical flu shot, it's trivalent, three different strains. Does not that always affect. So you're getting tetanus, you're getting what's called a cellular pertussis. The one that's the least effective is the whooping cough, pertussis, and of course diphtheria, which we talked about. And so the way, and you'll see it here, it's called Tdap, tetanus, diphtheria, and acellular pertussis. For a while back in the 90s, early 90s, it was just DT. They had the pertussis is the one that's a pain in the neck. It's the least effective. They reformulated it. That's where the AP came from. Back then, it's a little more effective now. The infants are the ones who are really at risk. We see it. I went through a thing where I had students in my classes for about a 5-year period where somebody had pertussis, not, oh my God, not flagrant, whooping cough, horrible, but basically they had a chronic cough that they couldn't get rid of. Sometimes they had it, typically it was parent with toddler, and the toddler had the same thing. And what had happened when finally they went to the doctor, one of the doctors that used cough syrup this and allergy pills that, finally said, let's test. And they diagnosed pertussis. It can be a very long-term chronic cough. Thankfully not as severe as this life-threatening disease that you're seeing, that really scary looking thing. But worldwide, this is 8 years ago, probably these statistics, 500,000 deaths. So understand thankfully we are immunized for this, and most people are on top of it. Again, vaccine laxity is a problem. Even though I don't like some of them, there's some of them that you do have to have it, and this would certainly be one of them. And so what happened, catarrhal is an old-time term for mucus. Oh, they have a catarrhal discharge. That was what the old docs said for who had, like I work with people like that who got their MDs in the 30s and the 40s. Oh, it's catarrhal. That was a fancy word for, you're dripping mucus. Okay, and typical upper respiratory infection, and then all of a sudden, paroxysmal means sudden, sharp, violent. That's what paroxysmal means with these coughs. So bad, blood vessels would break, it's struggling for air, and it gets its name whooping cough because I can't do it. It's like a respiratory inhale that's so blocked because it's hitting that mucociliary escalator and your stuff. It's like, it's different. There's something that kids get as a variant of RSV that's pretty common in toddlers called croup. It's not nearly as severe. It sounds a little like it. It sounds more frightening than it. And we'll see when we talk about RSV, which will come at the end of this. Typically, you see RSV is either in infants, very old, and that croupy thing that like my kids got, kind of got rid of with those cool mist humidifiers that you use. Maybe you had them in your room when your moms and dads put them in there. We just dragged my kids into the shower, into the bed, and we closed the door, turned it on real high, and into a steam room. We didn't throw them into a hot shower. Tempted. Very tempted. He calls me yesterday, my oldest. You know where I am? Where? Oh, I'm going to head to the beach in San Diego. What's it? It's 85 and gorgeous. Oh, really? You're done with work already? Yeah, they put him up in a great hotel. It's good to be an officer in the military. Moving on. But you can see all this terrible stuff that goes on. Vomiting, seizures. I mean, not really contagious per se. Okay? At that point in time, it's just the infants are very, very susceptible. Bordetella pertussis. If you know the word Bordetella, it's probably because you have a pet. If you're going to go to a kennel cough is Bordetella. Your maybe your dog, like ours does, I get a reminder from Camp Bow Wow. He's due. I got you. Make sure you take him to the vet. Fine. So a little gram-negative rod. The trouble is, if you're without immunization, these are toxins. Tetanus, diphtheria, and pertussis are all toxins. Once they start to produce the toxin, antibiotics might work on the bacteria, but you have to detox. That's what you're making. Your body is making what's called an antitoxin. And so you either have to give them the antitoxin if you recognize it, if it's available, but really the cure is prevention, so to speak. So, I mean, unfortunately, it's very difficult to deal with. And again, it's one of those AB toxins that I talked about previously. You don't have to know all those names and things like that. But it's a two-parter. One, A attaches. I mean, A is the active part and the B part is the attachment. And droplets, classically infants, most fatalities under 1 year. And this is suboptimal vaccination is really probably the secret sauce. I mean, I just read the other day, and I do this, and I'd recommend you do this. I mean, every time I see an article on a website or a newspaper about an outbreak of something, I wonder. I mean, I'm California, a lot of measles outbreaks, and this is, you know, the vaccine laxity that's problematic. And again, you can see the DTaP here. And then the last nugget we really do. Let me see if I get anything after TB. No, we just have TB to finish. Let's hear. Tuberculosis is the analogy. Cancer, you know, when cancer is so deadly in your lung, and cancer's anywhere, they metastasize. They're so little pieces break off because they don't hold together. They either get into the bloodstream or the lymph, and they travel all over. So, I mean, if somebody like me with my bladder cancer could have gone to my lungs, to the bones, to my brain. Thankfully, it didn't because we caught it early enough. Tuberculosis is an infection that acts like cancer. It's in your lungs, and the differential is lung cancer. That grows in your lungs, damages that boundary between all those blood vessels and all those alveoli, that thin boundary, it bursts apart and fills them in the bloodstream, and they travel over the body. So it spreads. We call it miliary. Miliary from the old term for a miller who would grind grain. Miliary means seeding. And it will go all, we call it disseminated is a better term. Spreads all over. I treated patients with tuberculosis in bone. If it gets to that state, they're in big trouble. Bone, lung, brain, just like a cancer. It's a very scary disease. And I mean, when they wrote this 8+ years ago, it started to go down from that uptick that we began to see in the AIDS era, because prior to that, it was fairly low. We are now seeing a reverse. That was one of the ones I was looking at in New York City. They've been studying for the last 3 years. Every year, they've seen an increase, and it's in overcrowded area, poor housing, real inner city bad stuff that we really don't see a lot of here in Pittsburgh, comparatively. We don't see the old projects, and that's what they still have a lot of those, unfortunately, in New York City and other big cities as well. So that's the best thing I can tell you about now. It's called Mycobacterium. That's that thick, waxy capsule. You tried to stain it in lab, my colleague, and that's the problem. Because what happens when you inhale it, and it's airborne, meaning that if you're in a room, I think I told you about this before, it doesn't drop to the floor. So in a room like this, if this was the room, imagine a hospital room, and someone has this and is coughing before they diagnose it, and you're coming in there, the more you come into contact, the more likely you are to contract it over time. It's got a small infectious dose, but really it's more about contact. It's being within their presence for a long period of time. It's very, very difficult. I told you about it when we talked about antitubercular medications. That's why they have all those personal protective equipment that you have to use, the N95 masks like we use for COVID, the exhaust system, etc. What happens, this bacteria gets gobbled up by a macrophage, and rather than being destroyed, it sets up house in there. And I call it hiding in plain sight. Your lungs, and you just did respiratory, I think, and A and P, the lungs are filled with macrophages. They're like little sweepers. They're constantly sweeping up the lung so it's free of microorganisms. It grows in one of those, and basically it starts growing and replicating. And by the time your immune system gets the message, it's already set up shop. And what happens is your immune system tries to attack this, and multiple layers of white blood cells try to get rid of this. It's called a giant cell. And what it forms, because these are granular cells, remember in blood you talked about agranulocytes and granulocytes, has a very granular appearance. We call it a granulome. And tuberculosis gets its name because that granuloma, all those other cells, begin to firm up, and over time they even can form calcium deposits. And so when they postoperatively, posthumously, in other words, in an autopsy, they used to examine the lungs. They felt these hard lumps, and they thought it was bone. So what's the name for a little small bony thing? Anatomy, a tubercle. Not a tuberosity, not a trochanter, not a spine, not a ridge, a tubercle, right? Hence tuberculosis. So you learn something new every day in anatomy. And the real difficulty with this is the inside, the combination of trying to get in here changes the environment, and it causes a very interesting kind of necrosis. It's kind of foamy, and we call it caseation necrosis. And it's sort of like a foamy, kind of white, kind of like wet cottage cheese kind of appearance. And it's teeming with bacteria. And what happens in the lung, here's that lining in the lung, and it kind of bursts through and spreads out all these bacilli, and they go through all the body. It's really, so a caseating lesion leaves a hollow. So you can see through this. And so we almost had it lit. That's the tragedy of tuberculosis. Until AIDS reared its ugly head, and we had immunosuppressive diseases and immunotherapies and things like that, when people had transplants, things, then we almost had it lit just by testing for it. We didn't use the immunization. The immunization is only used, it's typically used in other countries like India. I told you ages ago, my daughter had that when she was an egg donor on at least 4 or 5 different occasions traveling to India. And they made her, and at that time, her boyfriend, it's not her husband now, to go there. They both had that immunization because it's mandatory. It only works in kids, little kids, not in adults, but still part, because India is so overcrowded. I mean, if you ever travel there, it's just, she told me stories, it's amazing. It's how crowded. She was in Hyderabad. I'm probably saying that wrong. It's one of the small cities there that only has 1 million plus people. Just she's never seen any of that crowded, and that particular thing. It's very, very interesting the way she told about this. But in the AIDS era, we've started to see, they started to get a handle with treatment, but now we're getting a resurgence because of all I talked about, resurgent diseases, greater degrees of overcrowding, people becoming less concerned about it. I mean, there's a lot of things that have brought that to the particular use of immunosuppressive drugs, okay, that we use, that are advertised constantly for rheumatoid arthritis, for asthma, for psoriasis. Well, I took, they're immunosuppressive. Your immune system is your fighter. I mean, it's fraught with problems. Usually results starts as asymptomatic. Most of these are latent. Millions of people you encounter have latent TB. As long as they're healthy, it will not activate. So it's not an unusual diagnosis. It's when it becomes active that we have to treat it. That's there. And so that's the kind of thing that they would use to screen for. If you tested positive, they had other things that they examined at the time and determined whether to treat or not. And now The same thing applies now, but now they're probably much more aggressive with the treatment. And the big thing, it's kind of like cancer, night sweats. Waking up like on a cool night like we had last night, just cover, just your pajamas, whatever you're wearing in bed. It's just swinging wet, soaked. That only happens with cancer patients and tuberculosis patients, really sick people. Cough, that blood streaked, it's a little unusual. That when it spreads, it can get all the way around. Here's the acid fast that you can see. It's a bacilli, so it's a rod. And that's why the test is used, because it takes so long to grow in the lab. It might take 10 to 14 days in the lab to identify it. The test takes 10 minutes. And so we collect sputum, and that's what we'll say sputum for AFP, acid fast bacilli. And again, this is what I'm telling you about. The macrophages engulf it. They can't destroy it because of that capsule. And then you get all of this. It sends out signals. More white blood cells try to surround it. And eventually, what happens, that giant cell, others induced by bacteria, these oil droplets, they call them foamy macrophages. And that's the start of this sort of unique core of this granuloma, which is part of it. Okay? And they go through all this is, and these are terms I won't ask you about, Gone foci or Gone complex. And say, as you can see, a lot of cases, in many cases, it resolves and just becomes latent. We really only treat the active TB. And this is the one where necrosis, and that caseation necrosis, it ruptures, releases it into the chest with a cavity, and then it gets in the bloodstream because of the proximity. And that lung cavity persists for long. So it's very destructive to the lung and can be spread by coughing. They're showing you some of these hollow areas. This is where it's becoming foamy in here. And this is, you're starting to see the boundary of how large this is. It's quite remarkable. So again, 8 to 10 years ago, 13 million people have this. I know I'm running almost on the edge of time. And a small percentage will reactivate, but that's not insignificant. And then it doesn't take a lot. And again, immunological health, you know about the tests. And then this is the other nugget we talked about with anti-tubercular drugs. You got to be, it's how they classify them. Is it resistant to first-line drugs? And then if it's resistant to first and second-line drugs, I'm not going to ask you about that stuff. Okay? But understand, it's a very complicated, because you have to use at least 2 antibiotics for a year, and you have to constantly switch them every couple of years. And I think I'll leave you with that. I don't think we have a whole lot more to talk about with that. So we'll start with Legionnaire's disease next time. I know you can't wait for Legionnaire's. I was there when it started. That's right, I was there.